Bone pain in metastatic castration-resistant prostate cancer is a well-established prognostic marker. This goes back to 2008 when a study published by Dr. Halabi and colleagues in the Journal of Clinical Oncology demonstrated that higher pain interference scores at baseline are associated with worse overall survival in patients with mCRPC. Specifically, patients with higher pain score had a median survival of 10.2 months compared to 17.6 for those with lower pain scores. This highlights the importance of pain as a prognostic marker of clinical outcomes in CRPC. However, in the metastatic hormone-sensitive prostate cancer, or MHSPC, we have limited data in the literature coming from prospective trials regarding the impact of bone pain and survival outcomes. Also, in MHSPC specifically, there's a need for exploring novel prognostic markers at baseline because we are still offering similar therapy to most patients with MHSPC. However, given the heterogeneity of MHSPC, these prognostic markers can help stratify patients, guide treatment decisions, and identify those who might benefit most from aggressive therapies while sparing others from unnecessary toxicity. So our study is a post-hoc analysis of the SWOG 1216 trial. As a quick reminder, the SWOG 1216 trial was a phase 3 prospective randomized clinical trial designed to evaluate the efficacy of androgen deprivation therapy, or ADT, combined with either ortironel or baculotamide in patients with newly diagnosed MHSPC. So the trial enrolled from 248 academic and community centers across the US between 2013 and 2017, and patients were randomized 1-to-1 to either ortironel versus baculotamide. So back to our analysis, baseline bone pain was categorized as the presence of or absence of bone pain at the time of MHSPC diagnosis, and bone pain status was determined on physician's clinical assessment. The survival outcomes we looked at were overall survival and progression-free survival. And in the multivariable model, we included all the known baseline prognostic markers present, such as age, treatment type, Gleason score, disease volume, performance status, and baseline PSA level. So this post-hoc analysis showed again that the presence of bone pain could be associated with worse PFS and OS. So PFS was 1.3 versus 3.7 years in patients with versus without bone pain respectively, and the adjusted hazard ratio was 1.46. And the median overall survival was 3.9 years versus not reached in patients with versus without bone pain, and the adjusted hazard ratio was 1.66. So these findings can have several important clinical implications. First, for patient stratification. So bone pain should be considered a critical factor in prognostic models for MHSPC, aiding in more accurate risk stratification. Second, given the poorer outcomes associated with the presence of bone pain, these patients may be prioritized for enrollment in clinical trial. Why? Because the trials could provide access to novel therapies that might improve their prognosis beyond the standard of care treatment options. Third, we can use this data for patient counseling to inform patients about their prognosis more accurately. This can help in setting realistic expectations and in making informed decisions about their treatment plans. And finally, patients with baseline bone pain may require closer monitoring for disease progression and more intensive supportive care measures to manage pain and maintain quality of life. So again, like incorporating bone pain in prognostic models for MHSPC could improve the accuracy of survival predictions, allowing for better risk stratification. So research is warranted in understanding the biological mechanisms underlying the association between bone pain and the poor prognosis, which could provide insights into potential therapeutic targets. Also, understanding the molecular pathways involved in the bone metastasis and pain generation may lead to the development of novel drug in this patient population. Research should also focus on the impact of bone pain on quality of life and functional status. This include like longitudinal studies assessing how pain management intervention affect patient-reported outcomes, quality of life, and daily functioning. And again, developing and validating prognostic models that incorporate bone pain along with other clinical, biochemical, and maybe genomic markers could improve risk stratification and guide treatment decisions. And all this would help in identifying high-risk patients who might benefit from more or less aggressive treatment regimens.